I want to thank the panelists here. We got another panel after this one. I want to thank them for being here too. I want to thank my friend Senator Tuberville for filling in for Senator Moran, at least for the first part of this meeting. Yeah. Many veterans deal with invisible wounds of war. For some, that may mean challenges with their mental health. For others, they may turn to substances in order to cope with the burdens that they bear. And for many, these are linked. According to latest data, about 1.1 million veterans suffer from both substance abuse use disorder, and mental health conditions. Today, we have gathered leaders from the Department of Veterans Affairs, as well as researchers, advocates, and oversight officials to discuss how we can improve veterans' access to high-quality treatment for SUD. We know barriers exist, whether it be stigma, wait times, or finding the right treatment option. And for veterans in rural communities, like so many veterans in Montana, it can be even harder to access care. Rural areas often have shortages of healthcare professionals, and the VA is no stranger to that challenge. Almost 70% of primary care health professional shortage areas across this country are in rural or partially rural areas. And a recent study found that 136 hospitals in rural communities closed between 2010 and 2021. Improving access to care for rural veterans by purchasing care from community care may not be the answer, because rural areas are relatively underserved generally. You can't buy it if it ain't there. That's why it is so important to bolster the VA's workforce. I'm proud to say that through resources Congress has provided, VA has added some 1,100 positions nationwide since FY22 to improve SUD care for veterans. That's good work, and they need to be thanked for that. VA provides coordinated care to veterans with an understanding of the unique life experiences and conditions that the veterans face. However, there's work to be done to ensure all veterans have timely access to that care. I have heard numerous issues with veterans not being able to readily access VA's residential care for mental health and SUD, the RRTP program. That's why I included a provision in my Strong Veterans Act enacted last December to study RTP wait times and availability to better inform the development of additional RTP sites and bed spaces. Building off that effort, I will be introducing legislation very soon to make community care really work for veterans, and that includes being able to access residential SUD and mental health care in the community when that care is needed. For veterans who need this level of care, there is no time to waste, and we need to ensure they are given all the options available. I want to thank you all for being here today. I look forward to your testimony. I look forward to the discussion. With that, I will turn it over to Senator Tuberville for his opening statement.
Thank you, Mr. Chairman. And thanks for the witness for being here today to discuss this very important topic and a top priority of mine, which is veterans' access to substance use treatment. On behalf of Ranking Member Moran, I'd like to give a special welcome to Chelsea Simone, who's here with us today. She's co-founder and executive director of Hunter 7 Foundation. Ms. Simone is an Army veteran, flight medic, clinical nurse researcher, and an advanced practice provider. She continues to serve her country by advocating for her fellow veterans to get the care that they deserve. We're here this afternoon to determine if the VA is meeting the needs of veterans, specifically veterans who reside in rural and highly rural areas when they need treatment for substance use disorders. The VA continues to claim suicide prevention is their top clinical priority. Therefore, ensuring veterans have prompt access to high-quality treatment for mental health conditions and addictions is critical in achieving our shared goal of combating veteran suicide. As overdose deaths are increasing across America, and especially in our rural areas, so is the need for high-quality mental health care and addiction treatment. That is why I continue to wonder why the VA will not use the tools and authorities Congress has given them to save the lives of veterans who are most at risk. When veterans make the decision to seek treatment for their mental health conditions or addictions, VA must ensure that they are met with high-quality care that provides veterans with timely access choices and no red tape. I look forward to hearing from each of the witnesses today on this important topic, Mr. Chairman.
Thank you, Senator Tuberville. Now for our first panel, and I want to thank you all for having names that I should be able to pronounce. Dr. Erica Scavella, Assistant Undersecretary for Health for Clinical Services at the Department of Veterans Affairs. She is accompanied by Dr. Tamara Campbell, I guess I was wrong on that, Executive Director of the VA Office of Mental Health and Suicide Prevention, and Dr. Bradley V. Watts, Director of the Veterans Health Resource Center at the VA's Office of Rural Health. Thank all three of you for being here. Dr. Scavella, the floor is yours.
Thank you. Good afternoon, Chairman Tester, Ranking Member Tuberville, and distinguished members of the committee. Thank you for the opportunity today to discuss VA substance use disorder treatment programs in rural America. Accompanying me today are Dr. Tamara Campbell, the Executive Director of the Office of Mental Health and Suicide Prevention, and Dr. Bradley Watts, Director, Veterans Rural Health Resource Center. For the past decade, there has been an increase in morbidity and mortality from substance use disorders as powerful and illicit drugs have become more widespread. For fiscal years 2018 through 2022, the number of veterans diagnosed with a substance use disorder and receiving treatment in VA increased from 522,000 to over 550,000. VA is committed to ensuring all veterans have access to treatment for substance use disorder regardless of where they live. Core characteristics of substance use disorder services include timely same-day triage, a no wrong door approach, concurrent treatment for co-occurring needs, and veteran-centered and individualized treatment based on the needs and the preferences of veterans. Over the last decade, VHA has worked to mitigate risk factors associated with overdose and suicide among veterans related to opioids and stimulants, including launching a national opioid safety initiative and a stimulant safety initiative. Beyond treatment for substance use disorder, VA provides primary and secondary prevention specific to opioid use disorder, in addition to efforts specific to the risks associated with substance use in general. As an integrated healthcare system, VA is uniquely positioned to address the needs of veterans diagnosed with substance use disorder. Current policy requires facilities to provide access to the comprehensive continuum of care of substance use disorder treatment services, ranging from early intervention and harm reduction services through intensive outpatient and, when needed, residential or inpatient treatment. Current policy also requires facilities to provide same-day outpatient access to veterans with emergent substance use treatment needs. This care can be provided in person or via telehealth in several settings, to include our general mental health clinics, our primary care mental health integration clinics, and substance use disorder specialty clinics. VHA national policy explicitly states that veterans cannot be denied care due to their use of a substance. Further, both national and the VA DoD clinical practice guideline for the management of substance use disorders defined expectations that veterans be retained in care and that programs do not use criteria that would automatically discharge them from treatment. VHA offers comprehensive care and mental health residential rehabilitation treatment programs, or MHRRTPs, to veterans with co-occurring mental health, substance use, medical, and psychosocial needs. Today, more than 70 domiciliary substance use disorder programs are in operation with over 1,700 beds. We are focused on specifically providing intensive residential substance use disorder treatment. VHA recognizes the importance of timely access to the mental health residential rehabilitation treatment programs for veterans and require this intensive level of care to be available to them. We will continue to review our policies and address concerns from many stakeholders related to the concerns you mentioned. Veterans living in rural communities often face unique characteristics that limit their access to health care. Barriers such as long distances to clinical facilities and a shortage of qualified providers can put rural veterans and their families at risk. To overcome these challenges and reach rural veterans with critical health care needs, VA has expanded access through telehealth programs and leveraging the skills of our existing clinicians. This includes the development and ongoing expansion of clinical resource hubs, which are a network of VA centers in large urban settings that are skilled in delivering their services to veterans in rural areas at medical centers, VA community care clinics, and home through the telehealth services. In conclusion, we appreciate the committee's continued support with this shared mission. Nothing is more important to VA than supporting the health and well-being of the nation's veterans and their families. VA has employed broad evidence-based strategies to address the opioid epidemic. This critical work saves lives. My colleagues and I are prepared to respond to any questions you may have and look forward to working with you on some remaining barriers that make it challenging for us to meet this mission. We are committed to providing world-class care to our nation's veterans. Thank you.
Thank you, Dr. Scavella. To the second, I might add, on that testimony. I will start out with a few questions that I have. I come from a state that's pretty darn rural. In fact, in some departments, the whole state is considered a rural state. Even our most populated areas are considered rural. We have a treatment facility at Fort Harrison. It's a 24-bed. By the way, Fort Harrison is a long ways from Plentywood, Montana, okay? So it's our state capital. It's where we have our VA hospital, and they have a 24-bed residential treatment program for veterans with mental health, 8 beds for SUD, 8 beds for co-occurring SUD, and then 8 beds for PTSD. I've got 2 questions. The first question is, what makes VA unique and able to provide residential care for veterans that have comorbidities like SUD and PTSD? And then the second question is that how common is it? Because in my world, there's not a lot of treatment centers out there. There's just not a lot of treatment centers. So how common is it in rural America that the only choice they have is the VA for a veteran that has these issues?
Thank you, Chairman Tester, for that question. So to answer your first question related to why VA is uniquely able to provide the care to the veterans with these substance use disorder diagnoses and other occurring comorbidities. The first is that we are the largest integrated healthcare system in the United States. We provide comprehensive care for our veterans, from primary care through pain management, general mental health, as well as substance use disorder. And so we treat the whole patient, and we are able to see that due to the fact that we have an integrated record. We can communicate with our colleagues to provide that care. So that is one of the reasons why we are certain that we can communicate internally, do warm handoffs when required to pass patient information along to make sure we're providing that care. The second question that you asked, which is related to the availability of services in rural locations, you recounted your statistics in your state very well. We know that we have challenges, but we do have facilities in Montana specifically for substance use disorder, and our commitment is from the time of identified need to make sure that we're bringing those veterans in if they need inpatient or residential services, to start that referral and to get the care provided as soon as possible, preferably on the same day, but within 72 hours if it's for priority needs.
Okay.
Yes.
So I talked to you about the distance. So when you're referring to community care, oftentimes you have no choice. Oftentimes it's a long ways away. What role does that figure in your decision making? Distance from home.
So distance from home is important to us to consider. The average patient may have to drive an average of 185 miles or greater to get the residential inpatient, the residential services that we would like to provide to them. So distance is a consideration. What we want to do is provide the soonest care possible in the best way possible. If we can keep them within the VA system to provide that care, we will. If distance is prohibitive and or the time between the appointment referral and the time that the appointment's going to be given, we can make a referral to the community, and we do that through some of the authorities provided in legislation.
Okay, so what is the wait time for RRTP? Typically?
Thank you for that question, Chairman Tester. The first question that you're asking about the wait times, we have a goal of getting our patients in within 72 hours if it's for priority care. If it's for routine residential care, the goal is 30 days. We are able to meet that need in over 50% of our patients, but if there is a concern voiced by the veteran or the family, we can work with our community partners. I'm going to turn it to Dr. Watts to see if there's anything he'd like to add to that answer.
Sure.
Well, I think as you indicated, the challenge is often that there aren't community resources available for the most vulnerable rural veterans, even if we do want to make those referrals. So the action could end up causing the veteran to need to travel many hundreds of miles in order to achieve that care in a timely way. So it's often a sense of trade-off between those two.
Okay. And so, before I turn it over to Senator Tuberville, you said 50% of the time you're hitting the 72, 50% you're hitting the 30 days for routine too, or are you making the 30 days more often than that?
Our average time, Senator Tester, for the referrals is between 8 to 20 days when we look at our data. So we are hitting that. However, we are also being very aggressive with making sure that we are staying engaged with those patients, making sure that if something changes, that we're able to adjust our plan. If something changes and the acuity of that veteran, their situation changes, we can make those adjustments. And again, I'll turn it over to Dr. Campbell to see if there's anything she'd like to add to that answer.
Thank you again for that question. I just want to iterate that many of our veterans choose to stay within VA. And so if they choose to stay within VA, we will keep them in VA and engage them in other forms of treatments. We have step care models. So we may be engaging them in telehealth services or outpatient treatments while they're waiting for residential care because they've chosen or they choose to stay within VA.
Okay, thank you. Senator Tuberville.
Thank you, Mr. Chairman. Dr. Scavella, is that how you pronounce Scavella? I know people mispronounce my name all the time too. So never, right? Doctor, and this is for all three of you. I'd like to kind of get to the bottom of this. I just recently reviewed a memo issued on May 24th, 2021, signed by the Assistant Undersecretary of Clinical Services, which recommends all VA medical centers establish syringe service programs, also known as clean needle exchanges, for veterans enrolled in VA healthcare experiencing substance use disorders. Now, federal law prohibits taxpayer funds to be used to purchase needles or syringes for the injection of illegal drugs. Why do we believe that the VA is above this? I don't understand that. Doctor, could you start out? And if anybody's got any, just all we're looking for is information.
So thank you for that question, Senator Tuberville. One of the things that we understand from looking at the research is that veterans who participate in a syringe exchange program or people in general are more likely to seek care from the entity providing those services for their substance use disorder. So in addition to reducing the passing, the contracting of other infectious diseases through those syringes, we also know that there's a greater likelihood that they're going to look towards us, look towards that entity to get overall help with their substance use disorder. I'll turn it over to Dr. Campbell for some additional.
Okay.
Just to reiterate, and thank you again for that question, our job is for the protection of veterans and also for the protection of the public. So the comorbid and co-medical issues that present with IV drug use, HIV, and hepatitis C, we're able to help reduce that with this program.
Dr. Watts, you got anything to add to this?
Nothing to add.
Okay. I just don't know who authorized this, number one. I know if Secretary Madonna did, he's not a doctor. And so, you know, it's very concerning to me that we're giving out needles, you know, for drugs and when it's illegal, you know. So what authority does the Assistant Undersecretary of Clinical Services have to issue guidance to every VA medical center given the priority VA has had on care and pain management? You know, why is the memo not signed by the Secretary himself? He didn't even sign this. I mean, do you know? Do you have any follow-up on that?
So thank you for the question, Senator Tuberville. That memo was drafted, as you stated, in May of 2021 through the authority that the Assistant Undersecretary for Health for Clinical Services had, which is to oversee the clinical care provided as the Chief Medical Officer for the Department of Veterans Affairs.
Ms. Campbell, know anything about that?
Just to add that within the federal guidelines within the hospital, we provided them within our hospital setting.
Dr. Scavella, I wonder why the secretary didn't sign this himself. Do you know?
Senator Tuberville, I cannot answer that question.
Okay.
I do not know.
I'll ask him myself, but it's pretty concerning. Do you know who's administering this program at facility level? Do you know who
So,
has the authority?
thank you. I will ask my colleague, Dr. Campbell, to provide an answer to that question. Thank you.
So each facility, thank you, each facility certainly has a quad member medical director, as you know, chief of staff, and the SUD coordinator or manager over that program would assist in overseeing it.
Is this person also in charge of care management plans? Do you know that?
So they would have a team, a multidisciplinary team, sir, to help them with the planning, with the entire care team planning for this.
All right. Is the VA managing data surrounding these programs? Dr. Scavella, do you know? Or do we have data on where this is headed?
So we do have some data on outcomes related to our veterans and their ability to successfully engage with us for substance use disorder. We know through all of our multidisciplinary care plans related to substance use disorder that we have reduced the number of veterans who are starting opioids for the first time, that are taking opioids in combination with other medications such as benzodiazepines. We also know that we are seeing fewer deaths from accidental and intentional overdoses. So there are some improvements with the overall comprehensive substance use disorder program that we are very proud of as far as ensuring that our veterans are improving.
Do you know if we're just handing out syringes to newly, I guess, new patients from the VA that come in first off, and are we just handing out needles, or are we putting them in some kind of detox plan?
So thank you for that question, Senator Tuberville. We would be bringing our patients in for comprehensive care. It would not be provided in a vacuum, but I will rely on my colleague, Dr. Campbell, to add some details to that answer.
Thank you again. Dr. Scavella is absolutely correct. It is an entire team that works with these patients. They are not in isolation, and that team includes medical practitioners are included in that team, and we emphasize certainly the biopsychosocial approach to treatment.
Well, just a quick statement on it. I think this is pretty concerning when we're really not following the law here, and I hate that we fall back on an easy plan when we should be really, really helping these veterans, because we got a huge problem. You know, the fact that the VA, we're the country's largest integrated healthcare system, and it's administering a clean needle exchange program when they should be creating treatment plans for veterans experiencing substance use disorders. To me, it's not very common sense, and it's really, you know, I don't think we're doing the veterans. I don't think we're doing them right. So I think, to me, it's poor use of taxpayer money. And again, it's really a disservice, you know, when we got all these veterans out there, and a lot of them have huge problems, that we don't treat the problem immediately, and we're just kicking the can down the road in some of these situations. So hopefully, and I'm gonna write a letter to Secretary Madonna and get some answers from him. It's pretty concerning that, you know, we don't want to make it easy on ourselves. We want to make it tougher, you know, to make sure that we give good health care. Dr. Watts, I'm sorry I didn't have a question for you, but if you've got anything to add to that.
Nothing to add, thank you.
Okay. Thank you, Mr. Chairman.
Do you guys want to comment on the statement as far as treatment plans and furnishing needles? Is there a treatment plan involved before needles are furnished?
So thank you for that question, Chairman Tester. As Dr. Campbell stated, veterans would be engaged in a comprehensive care program to identify all of the underlying comorbidities, including mental health concerns, serious mental illness, also pain management, to work on a comprehensive plan to reduce the use of substances reduce the substance use disorder in that veteran. So yes, those veterans would be engaged in a comprehensive care plan with very specific goals in place. We would also be using incentives to encourage them to change their behavior. And we are providing comprehensive care for veterans before they get into a situation where they're using substances and identifying risky behavior very early on if possible. But then when they are in a situation where they need assistance with substance use disorder, we are providing comprehensive care.
Thank you for the clarification. Senator Brown.
Thank you, Mr. Chairman. Thank you. As some of this committee know, because I mentioned it fairly ad nauseum, I've been doing roundtables and Senator Tester's, and written also by many others in this committee. The PACT Act, done roundtables in almost half of Ohio's counties now. And what I hear, I'll do it at a VFW or a Legion or a DAV hall, and I will hear over and over the difficulty of transition from the military to civilian life, and hear generally many people I talk to, many former soldiers, Marines, or sailors will say that their commanding officers and the military doesn't really care that much about that easier handoff, to the point that veterans organizations and the VA don't know where these recently become veterans live. So, Dr. Campbell, one question to you and then a comment, and thank you, Mr. Chairman, for your time. Talk about the VHA proactive outreach to service members transitioning back to civilian life, especially on mental health and potential substance use disorders.
Thank you for that question, Senator Brown. So we have strong collaborations with the Department of Defense and interagency collaborations through our Domestic Policy Council. We are involved with the Transition Assistance Program, where we are interfacing with the Department of Defense with those veterans who are going to be discharged. We know that first year is a vulnerable year, and so we provide them with resources regarding the benefits that they have, as well as all the services that can be provided, not just mental health services, but medical services as well.
I hope thank you, Dr. Campbell. I hope that suggests that the VA continues to work with us on the Adam Lambert Improving Service Member Transition to Reduce Veteran Suicide Act. It's important that we do more there, and I'm hopeful that you'll work with us, continue to work with us on that.
Absolutely, sir. We have very strong suicide prevention outreach workers at every VAMC, and we are leveraging our governor's challenge as well as our mayor's challenge to help us.
Understand you're doing that at the VA and you work for the VA, but do you believe we are finding those men and women returning home? Or is the VA's finding them? Local veterans organizations are finding them. Ohio has one in each county veteran service officers in all 88 counties who work for veterans. Are these entities finding these veterans when they're coming home?
We are certainly collaborating with them. We know we can do a better job. We have quarterly meetings with the VSOs, and so we are leveraging every opportunity we have to find them.
Is it better than it was 10 years ago?
We are trending better than it was 10 years ago.
Okay. One comment. I want to quickly mention the Chillicothe VA, Southern Ohio. The Secretary has come out at my request. Seems perhaps unusually interested in that. It's the only rural VAMC in Ohio. It's important in Appalachia. The past year, my office has worked with community leaders and local VA staff to ensure the facility is resourced in a way that continue to serve Ohio veterans. During the Trump administration, it looked like it was slated for closure. Secretary McDonough and all of you and my office were working with the union, in essence saved it, but there still isn't the attention paid. I don't think it's as dedicated to the future of this facility as the veterans in Southeast Ohio, and it's mostly AFSCME members, AFGE members, and AFSCME are believing it should be. It's essential that access to treatment for substance use disorders, particularly including inpatient treatment, remain available for local veterans. So I just want to say VA must listen better than it has to Chillicothe, to me, to those advocates at this VA, which is, I think, probably the biggest employer in town, as it often is in smaller communities, but most importantly, a very, very, very important focal point for serving veterans. Just wanted to let you know that, how important that is, and remind you.
Yes, sir, thank you.
Senator Tillis, if you're ready. If not, I'll go to Blumenthal.
I'm ready.
You're up.
Thank you all for being here. I know that when we talk about veteran suicide, we always, I think, appropriately point out how many of those who are committing suicide have no connection to the VA. What do we know about the population, veterans who have substance abuse problems? I know it's hard to know what you don't know or take and roll by asking everybody that's absent to raise their hands, but do we have any data that would give us an idea of just how big the problem is and what the ratios are between people who have a connection to the VA and do not?
So, Senator Tillis, thank you for that question. We know that we are actively treating approximately 6.2 million of our veterans of the 9 million that are enrolled, and we know that there's approximately another 9 million that are not enrolled. We know that within our system for this most recent fiscal year that we have approximately 550,000 that are dealing with substance use disorder. So if we extrapolate those numbers to the population that's not coming in, it may be around the same number since we're essentially touching half. We do, as we previously stated, we have lots of outreach that we're doing to try to make sure we're meeting veterans where they are, working with our community partners to bring them in to service, and also just letting them know that we are here for them when they're ready to come in. Specific to data that's outside of our catchment area, I can check with my colleagues, but I don't believe we have that readily available, but we would be happy to get back that to you.
The reason I asked the question is that we have to find more ways to make more connections. And I believe that we're in a time-sensitive, unique position to do that as a result of the Camp Lejeune Toxics Act. I don't know if y'all have noticed, but there's a few of those annoying ads that come on about every 30 seconds on whatever TV outlet you're watching. And there's been some debate here about capping legal fees and doing those kind of things for people that are signing up for law firms. One of the things that I wanted to do was to simply put out, and we are going to file a bill, I'm going to talk to members about co-sponsorship, but something that I've told them to call the Patriot Bill of Rights. And that is simply an informed disclosure before you sign a retainer with an attorney who's going to help you with a case for Camp Lejeune. To say, did you know that you could call did you know you could call this 1-800 number to the Department of Navy? If you are not connected to the VA, here's the number for the VA. Here's the number of your congressmen and senators who do casework all the time and prevent you from having to pay legal fees. And then here are these veteran service organizations that are building expertise around this area who can also provide you help at a far lower cost than the legal fees. Have them fully understand all the tools that many of them wouldn't have. But just imagine, even if they decide to sign the retainer, if we can just get them to make the call and get connected, what benefit that has for the population. And we've got a free sort of opportunity here to increase awareness because the trial lawyers are trying to go out there and sign everybody. Why wouldn't we want to formally or fully inform them and potentially create a relationship that doesn't exist today? I mean, we could have hundreds of thousands of veterans make a contact they never made before. We can save their life. We can determine whether or not they have substance abuse problems and actually get them into care that you all do an extraordinary job of. So I'm hoping we're going to speak with more members about it, but it seems like it ends the debate of capping legal fees. It gives us an opportunity to touch a number of veterans. The first time that they may have ever be connected is through a law firm that's trying to make money and hopefully get a benefit for the veteran. But it seems to me to be a fairly sensible approach. What's wrong with my idea?
Senator
I kind of poisoned the well by positioning it as a sensible approach, but
Yeah, I will say that since this is the first time that any of the three of us on this panel have heard about this, and since the Secretary has not had an opportunity to weigh in, we would be happy to review.
We're going to
and-
send the text over to you. It is literally as simple as I've described it, so I'll be very interested to see what the department's position is on the bill fairly soon here. Thank you all. Thank you, Mr. Chair.
Thank you.
Senator Blumenthal.
Chairman, you know, I believe for some time that one of the challenges is outreach. Whether it's through the media or person-to-person contact. In Connecticut, we have a partnership between the Connecticut VA Health System and a group that's called Connecticut Harm Reduction Alliance, run by a very able young man named Mark Jenkins. And they've established what's called a ROVER program. ROVER program sends RVs, literally recreational vehicles, to provide harm reduction supplies to communities. I've gone around with some of them, and they are stocked with all the stuff that are necessary to provide what people suffering from substance disorder need. And the program in Connecticut has been tremendously successful. Now has over 35 of these rovers serving 26 communities, and it plans to expand nationally. As I mentioned, outreach, partnership with the VA. The VA can't operate in isolation. It has to seek partnerships with community groups like the Connecticut Harm Reduction Alliance. What plans do you have to try to seek to provide more access to substance use disorder treatment programs in the non-VA community?
So thank you for that question, Senator Blumenthal. We clearly understand within the Department of Veterans Affairs that substance use disorder, especially considering opioid use disorder, is a whole of government and whole of nation approach that is required. We do need to continue to leverage those community partnerships, as Dr. Campbell stated earlier, to make sure that we are reaching veterans where they are, especially if they're not engaged in our care. We do have several programs in place to address veterans who may be at risk, to include our overdose education and naloxone distribution program, to make sure that we are providing tools and education to give both veterans and their families and caregivers the signs and symptoms to look for if someone is potentially getting close to overdosing, and then giving them the tool, the naloxone, to actually do the reversal. So that is one of the things that we're doing. We're also engaged with many different community partnerships, to include the Governor's Challenge and others, to really identify veterans who may be at risk. The Hand Act provided for the ability to engage with veterans within the first year post-separation from the Department of Defense. So we're leveraging that as well, making sure that we are reaching those veterans where they are, participating in their TAP classes, to make sure that we are giving them the tools that they need to engage with us, perhaps not immediately, but hopefully when they think of it and realize that they have that benefit and they are entitled to that care.
I may have missed it in your testimony, but do we have, we use these figures, 21 veterans every day commit suicide. Is there an accurate, up-to-date number?
Senator Blumenthal, I'm going to turn that over to Dr. Campbell, but we do have some updates on that number.
So thank you for that very important question. As we all know, one suicide is one too many. And so we really are leveraging everything we can. That number has trended downward to 17 according to the last annual report, and we continue to review those numbers daily.
According to which report?
The last annual
the last
suicide.
annual report.
Yes, sir.
And how do you access data on veteran suicide? What kind of data is available?
Sure. Thank you for that question. And so we work with the CDC, and we use scientific methodology utilizing their definitions of what a suicide is to develop that report and to look at those numbers.
And how did they define suicide? In other words, is there a definition of suicide?
So that
Use disorder taken to a certain level can constitute a form of self-destruction?
that definition certainly is determined by the coroner's office, and they look at each individual case and determine that.
Thank you. My time has expired, but I will want perhaps to follow up on this issue. Thanks.
And there will be opportunities for questions for the record, Senator Blumenthal. That concludes our first panel. You got off lucky, because there's more people than that here, but there's a vote going on right now. Thank you guys for your testimony. I appreciate it very much. You are certainly welcome to stay for the second panel if you choose. And now I will introduce the second panel. I'd like to welcome Dr. Julie Kroviak, that is Principal Deputy Assistant Inspector General in the Office of Healthcare Inspections at the VA's Office of Inspector General. Then we have Dr. Jonathan Cantor, who is Policy Researcher at the RAND Corporation. Then we have Naomi Mathis, who's Associate National Legislative Director of the Disabled American Veterans. And we have Chesley Simone, co-founder and Executive Director of the Hunter 7 Foundation. Dr. Kroviak, you have the floor.
Thank you, Chairman Tester. And committee members, I appreciate this opportunity to discuss the OIG's oversight of VHA's substance use disorder treatment programs. The OIG's Office of Healthcare Inspections reviews the quality and safety of healthcare provided across VHA and communicates these findings through public reports. The majority of our healthcare inspection staff have significant experience providing direct clinical care to veterans, and such experience adds unique insight to our oversight work. This is particularly true of our mental health team, staffed with board-certified psychiatrists, psychologists, licensed clinical social workers, some of whom are combat veterans. These team members have cared for veterans facing the very issues we are discussing today. VHA faces significant challenges in meeting the needs of individuals with substance use disorders, and rural settings can pose additional obstacles in addressing these patients' needs. In that veterans with substance use disorders often have additional mental health diagnoses that place them at higher risk for suicide, seamless and timely care coordination is critical. The committee's focus on rural veterans is appreciated, as veterans living in highly rural areas are 65% more likely to die from suicide than those residing in urban settings, an unsettling statistic that VHA faces in addressing their top clinical priority to reduce veteran suicide. Our oversight is much broader than just major medical centers. We reach out into rural communities with our VISN and CHIP reviews that analyze VA rural facilities, including the most highly rural CBOCs. And our vet center reviews will review the mobile vet centers, important outreach units for many of our rural communities. To meet the increasing demand for services, including mental health and substance use disorder treatment, VHA depends on community care. The OIG has identified persistent administrative errors and communication failures among VHA, its third-party administrators, and community care providers, as well as between the care providers and their patients. These failures amplify risk for patients with high-risk mental health issues and complex disease. My written statement details 2 reports that provide insight into the complexity of coordinating care for patients with substance use disorder at 2 distinct stages of treatment needs. Earlier this year, we substantiated the allegation that in 2020 and 2021, North Texas staff did not follow VHA policy requiring that patients be offered alternative options for residential substance use disorder treatment within VA or the community when the wait time for this service exceeded 30 days. This practice not only potentially delayed the treatment for these veterans, but also has the potential to fracture trust between patients and the healthcare system upon which they rely. The second report describes the mismanagement of a patient at the Toma VA, a rural facility in Wisconsin who was suffering from acute alcohol withdrawal and subsequently died at another VA hospital. We found failures in the clinical management of this veteran that likely contributed to their death. Assessments and stabilization efforts for patients at risk for life-threatening consequences of alcohol withdrawal leave no room for error, especially in rural settings when transfers to higher-level care must be anticipated early. To improve the quality of administrative and clinical practices in rural facilities and across the system, VHA frontline staff need policies and guidelines that are clear, standardized, and current. For example, just last month, our office published an advisory memo alerting the Undersecretary for Health that VHA's mental health handbook had not been recertified as required by 2013. Handbooks support frontline clinical decision-making, and such direction must be clear, accurate, and current. Standardizing the oversight of frontline performance can also support consistency and accountability. Additionally, while it is important for VHA staff to inform veterans of all care options available for their needs, ignoring that the current community care framework does not adequately address critical gaps in coordination may further increase the risk to patients. Our office has published reports related to community care detailing delays in diagnosis and treatment, lack of or miscommunication between providers, and significant quality of care concerns. The OIG will continue to provide meaningful oversight to support and improve the quality of health care provided to our nation's veterans. We also recognize the need to enhance and adapt our work to best support this dynamic healthcare system. We remain grateful for the participation and cooperation of VHA staff across the country and for their commitment to caring for those who have served. Chairman Tester, this concludes my statement. I'd be happy to take any questions you may have.
Thank you, Dr. Kroviak. Next up, we have the policy researcher from the RAND Corporation, Dr. Jonathan Cantor.
Chairman Tester, and members of the committee, I want to thank you for your invitation to testify today on what is a pressing and urgent public health problem. My name is Dr. Jonathan Cantor, and I'm a policy researcher at the nonprofit and nonpartisan RAND Corporation. I've conducted extensive research on the geographic availability and accessibility of substance use disorder treatment for veterans, military service members, and the civilian population. In my testimony, I will discuss three main issues. First, the complexity of substance use disorder treatment for veterans, given the frequent existence of co-occurring mental health disorders. Second, a brief overview of the geographic accessibility of substance use disorder treatment for veterans. Third, why it is difficult to assess disparities in access. And then finally, I have a few recommendations to enhance data collection and reporting to improve our understanding of the geographic availability and accessibility of substance use disorder treatment for veterans. In 2020, around 12% of veterans 18 years or older had a substance use disorder, and approximately 1.1 million veterans suffered from both a substance use disorder and mental illness. Less than 10% of veterans with a substance use disorder in 2020 received any treatment. There are a multitude of reasons for why a veteran would not receive the necessary care. First, some veterans who use substances do so to self-medicate their post-traumatic stress disorder symptoms. Second, many veterans fear seeking mental health or substance use disorder treatment because it could negatively affect their career advancement. Third, co-occurring disorders often go unidentified. A practitioner may identify a substance use disorder or a mental health disorder, but not necessarily both. Fourth, the appropriate treatment for an individual with a substance use disorder and co-occurring mental health disorder is more complex than treating one or the other alone. A key determinant for whether an individual receives substance use disorder treatment is how far they have to travel for care. To date, there have been very few studies that have examined distance to substance use disorder treatment as a barrier to care for a national sample of veterans. In 2019, the Wounded Warrior Project partnered with RAND researchers to understand geographic accessibility of co-occurring substance use disorder and mental health treatment. Our calculations indicated that, on average, Wounded Warrior Project alumni were around a 10-minute drive time from the nearest substance use disorder or mental health treatment facility with a co-occurring program. In contrast, for these veterans, the closest VA medical center with a co-occurring program was around a 60-minute drive time from where the veteran lived. Our results were encouraging. Most Wounded Warrior Project alumni veterans were able to access treatment programs for co-occurring substance use disorder and mental health disorders within 60 minutes. Almost 1/4 of U.S. veterans reside in rural communities. There's a concern that it's more difficult for rural veterans to receive care given they must travel farther than veterans who live in urban areas. The geographic accessibility of substance use disorder care could also vary based on the race and gender of the veteran. Our study did not focus on these potential disparities because there are extensive data challenges in quantifying these differences. Such analyses should require at least detailed data on the addresses or at least zip codes of the veteran, as well as data on their race, ethnicity, age, sexual orientation, and gender. Finally, and perhaps most challenging, the data would need to include whether the veteran suffered from substance use disorder only or substance use disorders and mental health disorders. Drawing on my research and existing work, I provide several recommendations in my written testimony. I want to highlight two. First, the Substance Abuse and Mental Health Service Administration's Behavioral Health Treatment Locator could include additional information on specific treatment approaches available for veterans. Second, either the Substance Abuse and Mental Health Service Administration or VA should consider conducting regular audit studies among non-VA facilities to get a more accurate understanding of the forms of treatment offered, approximate wait times to the next appointment, and total capacity of the facilities for substance use disorder treatment. And they should vary the calls based on socio-demographic characteristics of the veteran. Far too many Americans, especially veterans, fail to receive treatment for substance use disorder each year. I'm confident that we can increase the number of veterans who receive treatment and reduce the number of drug overdoses. However, that will require an infusion of funding to improve current data collection systems, ensure that veterans can access the information necessary to make treatment decisions. Thank you for your time, and I'm happy to answer your questions.
Thank you for your statement, Dr. Cantor. Next, we have Naomi Mathis, Associate National Legislative Director of the Disabled American Veterans. Naomi.
Chairman Tester, Ranking Member Moran, and members of the committee, DAV is grateful for the opportunity to appear before you today to address concerns with access to VA substance use disorder treatment program. DAV members are injured and ill, service-disabled wartime veterans. They utilize the VA healthcare system at extremely high rates, which many depend on as their sole source of healthcare. Our 1 million plus members live throughout the country and provide us with an insight into their unique struggles with access to care. Our written testimony provides our entire position. However, I will focus on the challenges, barriers, and our recommendations. First, rural veterans face issues accessing health care similar to those faced by the general population, including a lack of transportation. In rural communities, distance to a healthcare facility, time, cost of fuel, and access to transportation are all exacerbated and known barriers to care. Veterans who lack access to public transportation or are no longer able to drive because of age, health, or driving restrictions rely on family, friends, or community service organizations. To help such veterans, DAV operates a fleet of vehicles around the country to provide free transportation to VA medical facilities for injured and ill veterans. While this program is highly successful and beneficial for the veterans we serve, we continue to face administrative challenges with expediting volunteer driver examinations. Specifically, there is a breakdown in the onboarding process for our volunteer drivers. For example, our transportation coordinator in Montana told us they had 30 applications for volunteer drivers. However, by the time VA completed the onboarding process, a year and a half later, only 2 applicants remained interested in volunteering. During my recent trip to New Hampshire, our coordinators there expressed similar concerns. By contrast, we are hearing of other facilities that can onboard in as little as 3 days. We recommend VA standardize and expedite the volunteer driver onboarding process VHA-wide. Next, the Philippines is the only foreign country in which there is a VA outpatient clinic to serve eligible veterans. In October 2022, we began receiving complaints from our members who indicated VA Manila had completely stopped dispensing controlled medications, including those undergoing mental health and substance use disorder treatment. Options faced by this population of veterans are to either stop the medication, utilize the community, travel to Guam, or to the United States whenever a refill is needed. Guam, American Samoa, Puerto Rico, U.S. Virgin Islands, and the Northern Mariana Islands face even greater challenges due to limited or poor infrastructure. Veterans living in these areas often have to take commercial aircraft, which are not disability-friendly, to get to medical appointments or fill prescriptions. Not one of the VA OCONUS has a specialty SUD program. We recommend VA conduct a needs assessment to determine if adding substance use disorder programming for outside CONUS communities is warranted. Mr. Chairman, an additional barrier facing veterans residing outside of the United States is the beneficiary travel self-service system, which was designed to automate the travel reimbursement claims process. However, there continue to be complaints regarding the slow processing of payments and improper payments made to beneficiaries. VA must fix and modernize the system in consultation with stakeholders on the beneficiary travel self-service system. Lastly, as we celebrate the 75th anniversary of the integration of women into the armed forces, we must remember that women veterans are the fastest growing cohort in the VA system. Therefore, VA must continue to accommodate this growing population and their gender-specific needs. As a combat women veteran, I experienced longer wait times for specialty care at VA than my male counterparts, including mental health care. VA reports fewer than half of all residential facilities have separate dorm space for women veterans, and only 13 programs have gender-specific services for women veterans compared to 27 programs exclusive to men. I will note that none of them are located in rural areas. Additionally, women veterans with substance use disorder who experience longer wait times for treatment could have an increased risk of suicide. This may be due to VA's lower capacity to address women's needs. We recommend VA conduct a nationwide analysis to determine if expanding gender-specific substance use disorder inpatient care is warranted. This concludes my testimony, and I look forward to any questions you and the committee may have.
Thank you very much. Now, Ms. Simone, we look to you for your testimony. Ms. Simone is the co-founder and executive director of the Hunter 7 Foundation.
Senator Moran, Senator Hassan, thank you so much for sitting here and listening today. This story is very personal to me as it's a lived experience, so I appreciate it. Today I speak before the committee as a licensed healthcare provider with advanced medical degrees, including public health and epidemiology, as well as specialty certifications. I've spent over 15,000 hours working in emergency medicine, long and short-term substance use settings, and military veteran-specific mental health clinics. I've published in numerous academic journals and presented at conferences nationwide. However, I speak to the committee today as a sister of a combat-wounded Marine losing his battle with addiction, as the child of an alcoholic mother and heroin-addicted father. I speak today as a disabled Army veteran dealing with constant, debilitating pain and the uninterrupted emotional burden I face daily. The testimony I share today is unfortunately entirely true. By 14, I had a job, I skipped school, and I never got my homework done. I got into fights and did everything I wasn't supposed to do, so I failed my freshman year of high school. At 15 years old, I lost my oldest brother to an overdose. My mother told me my 24-year-old brother planned to enter substance abuse treatment the following Monday. He didn't make it. He had shot up the night before with friends of my father's, and he had fallen asleep and began to choke on his throw-up. Instead of calling 911 and keeping him awake, those he was with had moved his body into the hallway where he choked on his vomit and died. Shortly after his death, I was expelled from school. My behavior was self-destructive, and I lacked structure and discipline. It was difficult to talk about my situation at home with those who didn't understand, especially those who I had just thought I was a bad kid, but never figured out to ask why. By 16, in 2007, my youngest brother had signed up to serve as an infantryman in the Marine Corps. We rode each other often, and while he was in boot camp at Parris Island, he loved it. He loved every single minute of it. And I had just graduated high school when my brother told me he was going to be deployed as one of the first Marines into Marja, Afghanistan under President Obama's surge to disrupt Taliban forces. He spent 7 months in southern Afghanistan. While he was deployed, I'd sit at night and watch the evening news and keep to myself in the loop about what was going on in the war. Every time I heard an unnamed Marine casualty occurred, my heart sank. It was almost daily. In total, 68 Marines were killed in action during that 7-month deployment, and 694 Marines were wounded in action. In turn, I enlisted in the Army. In August 2011, he redeployed to Sangin, Afghanistan for 8 months. 30 Marines had been killed in action, while 582 Marines were wounded in action. Of those wounded Marines was my brother. While he had lost men he considered brothers and witnessed his closest friends suffer near-death amputations from hidden explosive devices and others who had been physically ripped apart by RPK machine gun rounds, my brother felt lucky. He had sustained outrageous blast injuries from explosions and rocket-propelled grenades, one blast so severe that an MRAP vehicle had flipped over on top of him, throwing him from the turret, causing him to break 4 ribs, fracture his skull, and sections of his lower back. He came home, but the physical pain was moot compared to the emotional guilt and moral injury he tried so hard to hide. Over the next year, he struggled with pain, physical depression, and guilt overwhelmed his life. What began as a short-term Vicodin prescription for pain management became a full-blown addiction where he would steal fentanyl patches from the regiment's Navy corpsmen. He had kept his habit under the radar until a random drug test had found opioids in his system. 16 days later, he was discharged under other than honorable conditions for illicit drug use, and he was homeless, jobless, emotionally and physically unstable, and addicted. He was too embarrassed to seek help and suffered in silence. Around the same time, I suffered a severe spinal cord injury while serving in the Army. I remember the electrifying pain. It was like no pain I had ever experienced before, but my adrenaline was high and the mission made the pain seem non-existent. It wasn't until later that evening I lost control of my bladder and pins and needles drove up my leg, causing debilitating, painful paralysis. At 21 years old, I was told my injury led to the discs in my lower back, partially paralyzing my spinal cord, and I needed surgery. My military career was placed on hold, but that wasn't the case for the rest of my team. In months leading up to the major surgery I was scheduled for, I was given more than 300 pills of the mild opiate hydrocodone acetaminophen, better known as Vicodin. I was told to take them every 6 hours for pain. In case Vicodin wasn't working, I was given 100 pills of tramadol, a synthetic opioid that reduces the pain felt through the central nervous system. To lessen the right-sided leg numbness and severe neuropathy and muscle spasms, I was given 100 pills of Flexeril. My anxiety was front and center, so I was given 30 pills of lorazepam, the anti-anxiety benzodiazepine, to take as needed for anxiety. 2 weeks later, I received a call that one of my closest friends that I had known since I was 14 was killed in Dwalat Shah, Afghanistan. I felt hopeless, motionless, and stuck in time, and I couldn't move. The pain had gotten worse, and the more pills I took, the pain I had was less and less. And as time went on, everything became easier to deal with, or at least what I thought. I went through 3-hour surgery and was on the road to recovery. The first few nights were hell. I had severe nightmares, dreams I'd never wish on anyone. I'd wake up covered in sweat and unable to move, and the pain worsened. I was given 60 pills of oxycodone acetaminophen, also known as Percocet, and was told to stop taking the Vicodin as it may have been an adverse reaction. I couldn't swallow the pills without vomiting, worsening my postoperative pain. I was sent home with an 8-ounce bottle of Oxydose, liquid oxycodone. It helped with the pain. Eventually, it subsided as I healed. I felt great. Looking back, I cannot remember a time in my life where I felt that relaxed or carefree. I could sleep, my mind stopped overthinking, and my heart stopped racing. I wasn't sad, and I wasn't worried about the future. I was enjoying the present. And when I started to feel myself come back to reality, I grabbed the medicine bottle and I'd take another sip. Like most 21-year-olds, I didn't have a way to measure the amount I was taking, instead relying on my balance to let me know if I had taken enough. I don't remember much besides laying in bed thinking, isn't life great? I loved how I felt in those moments. It was an unmatched feeling. I took medication not for the physical pain, but to cover my emotional pain, which worked very well until it almost killed me. Late one night, I was laying in bed and I had drank too much. I laid back and felt a sudden sickness. I went to get up and felt my legs get weak. Using the side of my bed, I slowly slid to the ground, and I don't remember much afterward as I woke up a few minutes later covered in vomit. I cried as I knew what had happened. The next day, I knew I had to get rid of it, which wasn't easy, but what kept me motivated was returning to uniform and being with my team again. There is a reasonable probability that this is what kept me alive today. To this day, I know I cannot take Percocet as I enjoy it too much. While dealing with my situation, my brother battled something similar. He figured out his steps, and he ended up staying with my aunt on her couch. He was addicted to prescription opiates. When those ran out and he couldn't get more, he turned to heroin. He was alone one night and had shot up heroin and was discovered later that had traces of fentanyl. He passed it on our couch, and when our aunt found him, he was covered in vomit and not breathing. She called 911 and began CPR. His lips were dusky and cold. He was given Narcan, intubated, and rushed to the emergency department where the medical team worked to save his life. The doctor said it was a miracle he was alive. While my brother faced his battles, I received medical clearance to remain in the Army despite having a life-changing surgery. My provider told me that the chances of another injury occurring were highly likely. As mentioned, and as predicted, years later I suffered a re-injury, this time equally as painful, but I could still move and manage. For me, long story short, my career was over. It will always be the most dangerous time in any service member's life when you are leaving a tight-knit group and leaving a feeling of belonging and reintegrating into society that couldn't care less about you, your service, your situation, or your struggles. There is no team or tribe that you can turn to or fall back on. There is no safety net, mirroring, experiencing, and a fellow veteran for you to voice your feelings on. I went to bed as a service member and woke up the following day as a civilian. My pain had become increasingly worse. My temper was short and my frustration grew. I woke up one morning my senior year of college, and it was like a trapdoor had fallen underneath me. I had a commemorative military pistol from my unit, a Sig Sauer P250 45 ACP under my bed, and I lay down on my bedroom floor looking up at the ceiling with my pistol in my right hand. I pointed the gun towards myself and put the barrel in my mouth. I can still remember the cold feeling and taste of steel. The only reason I am still here today is twofold. I couldn't kill myself in my grandparents' house, and I reached out to somebody who served in the military, and I said to them, I'm not okay, and got the help I received. In short, I invite you to read the remaining of my testimony, as this is something very personal to me, and I appreciate the time. I know I went over, so thank you very much.
Ms. Simone, thank you very much. Senator Hassan.
Thank you, Ranking Member Moran. And Ms. Simone, thank you so much for your testimony. Just a couple of things. I was governor of New Hampshire as we began to see what had been an increasingly bad opioid and heroin epidemic turn to a fentanyl epidemic. The thing that gives me hope and the thing that has made some progress possible, although we have much more work to do, as your testimony indicates, is that people like you have spoken up about their experience, about the fact that opioids, and particularly this new class of opioids and fentanyl, is extraordinarily addictive, and that we have to treat substance use disorder as the disorder that it is. And we have a lot of work to go, both to help people get into recovery and stay in recovery and recognize that sometimes relapses happen, right? And treat it like an illness that way. We also have to go out after the unbelievably insidious cartels that are trying to drive up demand for this drug that is so cheap for them to make and easy for them to transport. I also want to thank you for talking about the difficulty of the transition period for service members, because what I hear from especially service women and women veterans in New Hampshire is how difficult this period is and how alone veterans feel, especially women veterans in rural areas. So I thank you for giving voice to that. I thank you for being brave enough to do it. And I know that everybody on this committee, both sides of the dais, want to work with you and veterans throughout the country to make progress on these issues and to make sure that veterans understand how deeply we appreciate your service. With that, I'm going to turn to a couple of questions to Dr. Cantor, just because what I want to do is not only recognize the problem, but talk about what's working and what's not and what we still need to do. And with that, Dr. Cantor, as we're talking about veterans, and particularly veterans who fall through the cracks as they transition out of service or as they're dealing with substance use disorder, or whether they're dealing with mental health challenges, we now have the 988 Suicide and Crisis Lifeline that veterans in crisis can call, and they can be connected to the Veterans Crisis Hotline for help just by pressing option 1. What impact has 988 had on connecting veterans to the Veterans Crisis Hotline?
Thank you for the question. I do not know of any specific research at present that has discussed or looked at the linkage between 988's Lifeline to the Veterans Crisis Line as of yet.
Okay. Is it an area that you think we need data about and explore?
Yeah,
yes.
I would agree with you, yes.
Okay. Because I want, part of my reason for asking the question is just so that any veterans who may follow this hearing know that now this crisis hotline is there, and the wait times are relative, I think they're averaging about 40 seconds if I've got my data correct, and that there is this option for people. And so I hope veterans will take advantage of this. The other thing I'd want veterans watching to know is that there are a couple of programs, the Buddy Check program, our Solid Start program, that are really intended to lift up veteran service organizations as they reach out to their peers to provide support. I also, Dr. Cantor, wanted to talk about telehealth. My colleagues and I have worked together on a bipartisan basis to expand access to opioid treatment. Last year, we passed into law the Mainstreaming Addiction Treatment Act, which I led with Senator Murkowski. That removed unnecessary barriers for doctors to prescribe life-saving medication-assisted treatment for people struggling with opioids, including veterans. However, veterans in rural areas may still have limited access to in-person health care providers to initiate and monitor substance use disorder treatment. So we're going now from about 150,000 docs nationally who could prescribe buprenorphine for opioid addiction to 1.8 million now that we've removed this barrier. But we still have to be able to get people in front of a doctor to get that treatment. So, Dr. Cantor, can you discuss the role of telehealth in expanding veterans' access to life-saving medication-assisted treatment?
Thank you for the question. I think since the COVID-19 pandemic, there's been this drastic increase in telehealth availability.
Yep.
And I think that it's an outstanding question. There has been some research that's examined the telehealth utilization rates,
Yep.
but I think it's still under review as to whether or not the effect of the quality of care that veterans receive differs between inpatient and telehealth.
Yep.
And I think without that being answered first, I think we just need more information and data.
Yeah. Well, one of the things that I'm trying to drill down on here is if you have veterans in a rural area who don't have a primary care doctor in the area or a doc who's expert in treating substance use disorder, we need to get people in front of a doctor and begin that relationship. I'm going to continue, Mr. Chair, to push for telehealth resources when it comes to treating opioid abuse or disorder, because if we are expecting people to drive hours for this kind of treatment, I think it's going to be an effective denial of access to them. Thank you for letting me go over.
Kansan can relate to what you say. Senator Cassidy.
Thank you all. I've been pulled every which way, so if I sound like I'm asking something which others have already asked, I apologize, because I probably am. Ms. Simone, your statement that military veteran care should be less about the VA and more about the veterans themselves. What a powerful statement. And as we know, oftentimes it becomes the other way around. It becomes more about the institution than it is about the veteran. So can you just say what should we be doing to make sure that the VA provides the services that veterans need when they need it in a location which is convenient?
Sure, I appreciate that. Yeah, I've noticed from being a veteran myself and utilizing the VA, but also being a healthcare provider, that we start to come to these hearings and we hear more about the actual, the VA, less about the veteran. And so, for a lot of these veterans, post 9/11 specifically, less than 40% are enrolled in VA care. So when you look at the rural health aspect and you look at somebody who's suicidal or has a dual diagnosis of, TBI, chronic pain, mental health disorder, you got to look at it holistically. You can treat one thing, you can treat substance use the day of, sure, within 48 hours, but if you don't have something to back that with, physical pain such as myself, or emotional pain, I was discharged honorably, but medically retired. I was without my team, so mental health is lacking. Polytrauma, substance use, dual diagnosis, we have nothing to do that with. So when a veteran comes to me and says, I'm in crisis, I know my time is limited. If that veteran's addicted to substances and they're wanting treatment, you have to meet the veteran where they're at. You can't expect them to drive hours away or wait days. Hours is too much. It takes 10 minutes from the time you have a thought of suicide to the action itself. 10 minutes. That's a short amount of time. And if you can't help a veteran when they say, I'm ready, because you can spin your wheels and you can say, hey, we have treatment available, but if they're not ready, if they're not committed, they're not going to do it. You have to bring health care to them. And with all due respect, as somebody who has telehealth and virtual care, I can tell you right now, as a provider, that is not the right route to go for substance use, because you cannot physically assess that patient. You can't physically determine if they have injection marks on their arms. You can't see if they're currently struggling. You can't see below my legs where I can't stop moving my legs. So we need to meet the veteran where they're at. And it doesn't matter the extent of how that is. You just make sure you get it done, and these are people I served with. If I have to stay awake 24 hours a day and make sure that they're okay and they don't kill themselves, I'll do that because I love them.
As a doc who greatly knows the advantage of being in a room with somebody to give me information, I can totally relate. Dr. Cantor, you kind of put the statistics on this, that your testimony showing that less than 10% of veterans with a substance use disorder in 2020 received any treatment. And a key determinant is whether an individual receiving SUD, how far they have to travel. Now, Ms. Simone, a health provider, finds telehealth as a poor substitute for in-person health. Any comments on that?
I think that we just basically need more research in terms of the quality of care for telehealth. I know I've already stated that previously. I think that there isn't enough known currently in terms of to determine whether or not one provides better care versus the other. I just think we need more information. But to your point about veterans in general, about not receiving care, I think it's a persistent issue across the healthcare system. It's not just veterans. A large, significant proportion of the country doesn't receive care for substance use disorder as well. So I wouldn't just say it's just a veterans issue in terms of lack of care.
So is the issue specific? We know about the deaths from despair and how that is often centered in men and now increasingly women who don't attend college or don't graduate from college, et cetera. So are we talking about a veteran issue or are we talking about a demographic issue? Because you mentioned how it's true whether you're a vet or not. So again, is this peculiar to veterans or they're just part of that same demographic?
I think it's a system-wide issue. I think veterans have unique challenges in terms of both receiving treatment and then comorbidities when frequently having mental health issues along with substance use disorder. So they're a very unique population, but in terms of actual capacity and delivery of care, I think it's a system-wide problem.
It seems like that a veteran would have more options for care because the veteran still has the VA plus a more traditional healthcare system. So is that not a correct analysis?
I think it's just that mostly that most folks who need care don't actually receive it.
But I'm a little frustrated on this, and I'm sorry. Are they not receiving it because they don't seek it, because they're too much into their addiction and they don't want to get out of their addiction, or because they don't have access to the resource even if they want to get out of their addiction?
For veterans specific or just people in general?
Well, let's just stay with veterans.
I think it's a combination of both, that there's a lack of knowledge in terms of where they can receive care, and it's difficult to navigate the actual system, and the fact that whether or not there's numerous barriers about care, but I don't want to just oversimplify any one individual person's decision as to whether or not to seek care.
Yeah, but unless we have some sort of, not simplifying an individual, but unless we have some sort of kind of, we actually feel like, 40% of people just don't want care. They're in their addiction, they'd rather be an addict than actually go seek care. I worked in an inner city hospital, and frankly, that's kind of what I found sometimes. But we need to have numbers behind that, because we're being asked to apply resources, but unless you have a sense of what the need is and the particulars of it. So anyway, okay, I yield.
Thank you, Doctor. Senator Manchin.
Thank you, Mr. Chairman. And thank all of you. I appreciate very much y'all being here. Dr. Koviak, according to the U.S. Census, we're the third most rural state in America, West Virginia. We don't have one city or one town over 50,000 population. So we're a state of towns, about 1,800,000 people. But with that being said, how do you all determine what a rural veteran is? What's your determination of rural veterans?
So in our oversight work, where we would look to VHA's definition of rurality, so they have highly rural and rural locations that are based on data. I believe it's with HUD, and I'm blanking on the other, but they have a system in place that we follow when we conduct our oversight work.
Yeah, if you could get back to me
Absolutely.
on that, because my whole state should be. I have 4 different veteran hospitals and some clinics. Also, I was going to ask you on services. I understand we're having a hard time. Basically, in a very rural area, we have a mobile VA clinic. Are they able to treat for substance abuse?
So there are mobile vet centers that don't provide treatment but can serve to set veterans up with clinical support for detox, withdrawal, more intense services, as well as long-term substance abuse treatment.
I'm saying if they're far away from a center, and they need services and they can't get to the centers on a frequent basis because of transportation, is the mobile service available to them?
So I would have to get back to you on whether the mobile services can actually offer the intensive treatment you're describing.
One final thing from the clinics. I was at, we've had some problems, as you know, in some of the deaths that we had in one of our hospitals. But I was there talking about substance abuse, and I had one of the nurses who was very straightforward, and she says, well, if you all didn't call and raise so much cane with us about, because we won't give veterans their drugs they want, because if we don't give it to them, they would call and rate that service at that hospital as poor and give them poor ratings, which brought more scrutiny. Are you familiar with all this?
So I understand the concern they're fighting. I'm not familiar with the specific statistics.
Do you know if that's been changed?
I
understand we put a piece of legislation that changed. You cannot complain about the disbursement of drugs, because I can tell you a lot of the veterans knew exactly, they knew more than the pharmacists knew about what drugs they wanted and why they wanted them. And they would determine to get those drugs. And if they didn't, they would call their representatives, with senators or congresspeople, and complain they were getting poor service. And we found it was mostly over drug dispensing. You have I can see that you look like you want to say something.
If I could just add, though, it is a fair concern. The pendulum has swung dramatically, and veterans who are on chronic opioid or any type of chronic pain treatment, to aggressively taper is not an appropriate form of management.
We're not saying aggressively. Some of these nurses know better than what anybody else knows.
No question.
They're not able to do their job, but I'm hoping that is reversed. Does anybody up there know about what I'm talking about? Have you heard that? Chelsea, you want to talk?
Yeah, I've heard about it, and I've experienced it, and it's twofold, like you mentioned.
Tell me which way it's going.
Well, so it's not always a veteran that's seeking the drugs. You know, I mean, it's a interesting move, but I bring this as 1 month of pills from the VA that I didn't ask for, that the providers thought I needed. And I said to them, if I take all these, I probably won't wake up. This is 1 month. And so, with all due respect, trazodone to help me sleep, ropinirole, and
is that on a daily basis?
This is on a daily basis.
Oh, someone take a picture of this.
So, but this is so it's not always the veteran that's asking for.
So
this.
it's basically being prescribed to them.
We're not looking at it from a holistic
You got to be kidding me.
perspective.
This is.
Oh, there's two more. There's two more.
Put them all out there. Yeah, please get this.
And so, if I take these together, there's a good chance I won't wake up. And thankfully, as a healthcare provider, I know I can't take this with this and that with that. But these are all my pills, and so...
Have you talked, I mean, knowing that you have the medical expertise, have you talked to the providers why they did this?
When I said to the provider, I went to the VA two months ago, and I said, my back is getting worse, my spine is collapsing on itself, I'm 32 years old, go to physical therapy, here's some more gabapentin, this should help with the numbness. I said, that doesn't work, I've been doing this for 10 years. What else can I do? Oh, you can have a spinal fusion, so I can't walk. I said, that doesn't work for me. I can't sleep, I can't stop tossing and turning, and it's solely based on an injury. And so if this isn't an addiction in the making, and this is recent, this is 1 month, if this isn't an addiction in the making, I don't know what is. And this is why it's critical to see patients in person.
Well, this is what I was saying too. I've been told basically, and I've talked to a lot of our service members who have been deployed, and they're able to get anything they want, any concoction they want, just to get through the day.
Except if they want alternative treatment, respectfully.
It's a shame, isn't it? Mr. Chairman, we got to do something.
Thank you, Senator Mann.
Thank you, Mr. Chairman, and boy, Ms. Simone, that's some serious
teed it up for you.
Drugs you got there. You know, we've had hearings on this. I want to commend Senator Manchin. He's done a lot in this area on this topic. Dr. Kroviak, that wasn't one of the questions I was going to ask, but is that a concern from the IG's office about these kind of prescriptions that could lead to a dangerous situation?
That is catastrophic care coordination like I've never seen, and it is a huge concern when multiple providers are involved. usually we see the greatest concern between VHA and the community when that information isn't being shared in real time. Dangerous concoctions can happen like this, and patients might be completely unaware.
So were those all from the VA?
Yes, sir.
How many providers? Does that come from more than one, obviously more than one provider?
Neurology, mental health, and that's it. 2.
From the same VA? Which VA is that?
New England VA healthcare system. It sits in the New England VA healthcare system.
So there's a misstep in medication reconciliation, and I obviously don't know the specifics of your care, but that sounds like a big gap in medication
Yeah, you might want to look
reconciliation.
into that, right? We don't want anyone from that system or any of our veterans dying of a drug overdose that is induced by too many pills. That's outrageous. Let me turn to the topic at hand. Dr. Koviak, and by the way, I want to thank all the witnesses. A lot of you are veterans and are caring for veterans. Not easy, so all 4 of you, I actually appreciate very much. I read all your backgrounds. Impressive what you've done and your concern. So thank you to all the witnesses here. Do we have a sense, just going back to some basic issues, on wait times with regard to the VA, and is there a significant difference between urban and rural areas in terms of wait times?
So we do look at those, and rural versus urban, we do see somewhat of an increase in rural. If you look at fiscal year 22, it's not, I think some of the mental health differences for referrals were 7 or 8 days difference, and I can get those exact numbers that our office drew from VA data, but it is measurable in terms of when you compare rural to urban, that rurals have a longer wait time, especially for specialty care.
Okay. You know, I come from a state with more vets per capita than any state in the country, and we're a very rural state, Alaska. We don't even have one full-service VA hospital in the state. And one of the issues that my state has experienced, particularly with regard to rural providers, is the lack of experience in terms of the providers themselves. And so can you speak to that? Are there recruitment efforts that are being made with regard to trying to get more experienced providers in our rural areas? Maybe this is an issue just beyond Alaska. And what can we do about it? Is there pay scales that we can provide? Are there incentives that we can provide to make sure we're getting high-quality providers to people in rural Alaska? It shouldn't matter on your zip code how good your VA or private care provider is.
So I appreciate the question. Unfortunately, in oversight, we have no role in determining VA's hiring or retention and recruiting activities, so that would be better directed to them. But if I could just say, we do understand the quality concerns that you're describing, particularly, again, when you go out into the community, that clinical information sharing opportunities are lost or so delayed that I can't tell you what type of quality of care is happening outside of the VA, and I'm very concerned they cannot either. So your concerns about the caliber, the credentialing, the experience of the providers they're hiring in VA as well as in the community is definitely warranted.
Let me ask one final question. I'll throw it out for all the witnesses. Senator Cassidy, Dr. Cassidy, was talking about this issue of the prevalence of substance abuse in the veteran population, and then beyond just the veteran population. Dr. Cantor, he was having a discussion with you. But it also certainly seems like it's a younger generation issue. Is that a trend that you're seeing, any of you, in your experience, that these substance abuse issues are hitting a younger demographic? And if so, why? And if not, then maybe that's not an area of focus. Anyone on that? No one knows whether, go ahead.
I can speak on behalf of civilian. I work 40 hours a week in the ER doing 3 on 4 off, and I see roughly at Mass General Hospital 10 overdoses a week in just my practice alone in individuals under the age of 35.
So it is a younger demographic.
From my practice and personal experience, yes.
Anyone, Dr. Cantor, have you seen this as a broad demographic trend, or you don't have the data on it?
I do not have the data on that.
Anyone else?
I don't have the
Kroger.
data, but if I could just, if you're targeting an age group, we are doing work now in that high risk transition period from active duty to civilian or to veteran, when you will find typically a younger age. And we are doing work now looking specifically at ensuring that those diagnosed during active duty with opioid use disorder, that information is translated into the VA record. We are seeing there are a lot of gaps in even ensuring that once the diagnosis is made in active duty, that veterans are being recorded as having that diagnosis and immediately getting treatment and support for it. So it does softly hit your age target that you were describing.
Okay, good. Thank you. Thank you, Mr. Chairman.
Thank you, Senator. Maybe Dr. Kroviak or anyone. So are there statistics that, let me preface what I'm going to say. So 2014, we saw a inability of the VA within their hospital system to meet the needs of veterans. It's when we learned about the fake waiting lists, the fake appointment lists, and we responded, Congress responded with choice in 2014. So for 10 years, we've been trying to figure out how we can get the Department of Veterans Affairs to provide health care in more locations by using community care. Community care existed before choice. My view is that choice was implemented by the Department of Veterans Affairs, in which it needed more greater restrictions in our language to make sure that community care was actually provided. We had to encourage the department to use that option. So we passed mission, giving some pretty specific directions and outlines in which the circumstances, and again, only in the circumstance in which a veteran wants to have community care, and still we find that the gaps continue. My interest in this, is broad across the country, the deaths in the hospital in Arizona, et cetera, but it's also very local for me. I represent a congressional district at the time that is the size of the state of Illinois. There's no VA hospital, and it's hours to drive for almost every veteran to a VA hospital. And so we've tried legislatively to encourage, force, require, when the choice was the veterans, to receive care in the community. Any Inspector General reports that demonstrate any success in those efforts? Are things getting better? Do we still have problems in the utilization of community care? I have legislation that we're going to, I hope, mark up soon that will require you to make those analyses so that we can determine whether or not the efforts that we've undertaken over a decade are making a difference. Any commentary?
Your question is massive. It really is. And I'm a bit biased as a former provider in the VA. What choice didn't solve, what mission hasn't solved, is when you are engaging with the community, reliably getting that clinical information back, so VA and the community provider are on the same page at the same time to manage the veteran's care. It gets so much worse when there's complexity introduced. So if there's a mental health diagnosis, if there's a cancer that requires multidisciplinary specialties to get involved, the coordination is enormously difficult, and it remains so. And technology is likely the ultimate solution, but we are not there yet to where the EHRs can interface to have that real-time connection going. Every report the Office of Healthcare Inspection writes touches on some form of care coordination, gaps, failures, and they're usually highlighted in that community care collaboration setting. So until there is a way to ensure that a primary care provider in the VA who sends their patient out to the community for that dermatology, cardiology referrals until they can know in real time how that patient's being managed, you have no assessment of the
What's
quality.
the current capability?
It depends on the part of the country. You know, there are HIEs where our understanding is very few community providers participate in the health information exchanges. We are still, especially in some rural communities, relying on faxes, and those faxes get sent to a space in a facility where already a stressed staff in terms of number have to just scan those records in. And we don't even find there's uniformity in the scanning. So the record might be there for the provider to look at, but they have no idea how to find it. What's the naming convention? It's a dangerous relationship right now.
And are there other reasons? Perhaps you're suggesting that a provider within the VA would be reluctant to make the referral because of the lack of communication between.
So I don't want to imply that they would delay care intentionally for their patient, but when we do hear stories where the veteran is choosing to stay, I can, honestly say I get it, where they're choosing to wait for the VA provider as opposed to be sent into the community. But I don't want to suggest that we have anything that VA providers are scared to send their patients so they don't, because that is something we haven't looked at.
I would tell you that anecdotally, so many times I have, mostly what I know about what's going on in veterans' lives is the conversations I have with veterans. No offense to Rand or to the Inspector General, I should read your reports and analysis more frequently. But veterans are willing usually to have a conversation, and so often it is that I'm seeking community care, but I can't get the referral from the Department of Veterans Affairs. So there seems to me to be some bias if it's based upon a concern about medical care, but it's certainly a slow process by which the VA will make the decision when a veteran asks for community care. And what I've heard in the time that I've been here in front of this panel is that there is no time to spare. And so a system that is designed to save lives and improve one's well-being, particularly, I suppose, it could be other things than mental health and drug addiction, but certainly in those circumstances, we need a system in which a referral is made quickly. I understand that in many communities across Kansas and the country, there aren't enough providers in mental health and substance abuse services to make those referrals to. It's a shortage across the board. But it's a goal of mine to make sure there are no artificial, unnecessary impediments or no bias against a veteran who chooses or needs care quickly or needs care because of geography, that the VA is not making those referrals in a timely, medically necessary fashion.
Again, that's a huge undertaking, and I really appreciate the concern. And even if you take it out of this one aspect of community care you're looking at, this is a massive system, and it has a lot of policies and practices in place. And getting frontline staff to consistently apply those rules is difficult, especially when you don't have standardization across the board that builds in that accountability. In my oral testimony, I highlighted incredibly dated handbooks and guidelines for clinical practice. So we can't fix the interface of EHR today, but things that we can do in the immediate term is update the policies and practices, clinical and administrative. Give the frontline a chance to practice the rules consistently, and then standardize some type of structure at whatever level, maybe even looking at the VISN, to make sure those rules are being carried out. That's an immediate or a near immediate solution that will at least get you more comfortable that the staff is offering the veteran, based on the wait times, care that they need, an opportunity they have to get care outside the VA.
Well, it's another experience, and as an Inspector General, you wouldn't, I don't think, find this surprising. So many times, I bring a case to the Department of Veterans Affairs, and nationally, here in Washington, D.C., I'm told that this is the policy, and if it wasn't the policy, we've now fixed the policy. But that is never, well, let me be more precise. It's often the case that that's not what the person in the VISN or in the hospital or in the community outpatient clinic That's not what they know the policy to be. So I'm often told, here's the policy. Senator Moran, we've got the policy that you want, but that is not close to what
The
veterans are being
SOP,
told.
the local business rule might be completely different. So the frontline staff is being honest. Here's what I do because I'm told to do this. And they're being honest when they're delivering the policy. And when they conflict, who loses? The veteran.
I'm not off this topic. I mean, I'm off this topic for the moment, but I'm not off this topic generally. Let me highlight how grateful I am to Ms. Simone for what is a very difficult testimony to provide. I appreciate you sharing your personal and family story. You indicated in your testimony that the data you shared with the committee also notes many examples of where care offered by the VA has fallen short for many of your fellow veterans. Would you expand on what you're telling us?
Of course. You know, you're the senator of Kansas, so I mean, a perfect example, you know, in terms of community care.
You got something else in your bag?
No. No, I wish. I usually have a lot of, no. You know, it brings me back to the fact I deal mostly with oncology and veterans with terminal cancers, and you know, SOP goes out the window when time is on the clock. And I mean, I say that in the most humble way possible, but year to date, we've lost, only the ones that I know of that I've physically cared for, 119 post 9/11 veterans from cancer. And so 2 years ago, we had a veteran who was in the Kansas VA healthcare system. He was on his third diagnosis of terminal cancer, and the VA said to him, there's nothing more we can do. And being he was only 34 years old with 3 kids, I didn't accept that. I said, let me try, let me call, let me do something. And so we finally got him care down at MD Anderson. And when he requested through his provider, who writes the order or the allowance for community care, his provider says, that's not evidence-based, you can't go there, I'm not writing that order. And we fought for 2 weeks, and as 2 weeks goes by, time is running out. Finally, I said, I'll pay for it myself, because you can always make more money, but you can't save a life once it's gone. And myself and my coworker, Matt, reached out to your office, and you had him squared away instantly. And it saved his life, and he's still alive today, which is incredible, because he was given a terminal diagnosis 2 years ago. So this is something we face every day. And I mean it in the most humbling way possible. I don't have time. My patients, my veterans, the people I served with, myself, my brother, we don't have time to wait for processes to be implemented or systemic problems to be fixed. Time is running out. 24 hours in a day, time is running out, and every hour that goes down, that time matters. And if I have to pay for it myself, I will, because you can always make more money, but you cannot save a life once it's gone.
That wasn't the answer I was soliciting, but I appreciate the fact that you took greater willingness to go another step to make a difference. It's also a good reminder, and I make the same mistake. I talk about the Mission Act in terms of geography, which is a huge component to people, substance abuse and mental health issues and suicide and just general care. But the Mission Act is also designed to get expertise that may not exist within the VA, perhaps such as oncology, that can also serve a veteran if that's, again, his or her choice. You know, Ms. Simone, that I recently introduced the Veterans Health Act that aims to address some of the issues that we're talking about today. Would you share with me, so I can repeat it when we have a debate and conversation about this legislation, why your organization decided to endorse that legislation?
Absolutely.
Please do. Please tell me why your organization endorsed that legislation.
Oh, sure. So
my wife tells me
bad hearing.
My wife tells me I'm a terrible communicator, so I
can't hear that well. So our organization supported that legislation because, you know, at the end of the day, it's, like I said, it's not about if we vote Democrat, Republican, you know, whether veterans, whatever it may be, this is about the veteran. And so the Health Act I found very interesting because it allows us to get the veteran care where they're at. And for a lot of these rare cancer cases, and a lot of these are rare cancers that we deal with, substance use, like I mentioned, it's dual diagnosis and polytrauma. It has to be looked at holistically. And so a lot of my patients end up dying because they don't receive unique veteran-specific care. And I believe that your Health Act can make a big difference in that. I believe that they'll be able to receive care at some of the best hospitals in the country, such as MD Anderson, such as Moffitt, such as Dana-Farber, more quickly, more adequately, more holistically. And at the end of the day, that's all that matters to me and our organization.
Thank you. Ms. Mathis, your written testimony included a recommendation to the VA to increase the number of clinical resource hubs to better aid veterans who live in areas that experience bandwidth problems. We've been talking about technology. We've been talking about telemedicine, telehealth. My staff and I are proponents of this initiative of the Office of Rural Health and routinely ask the VA if they are requesting adequate funding for clinical resource hubs or could benefit from additional hubs. In addition to serving on this committee, I'm an appropriator as well. Can you share with us DAV's recommendations on how many additional clinical resource hub VA could use to serve VA's rural and highly rural veteran population?
Thank you for that question, Senator. I don't have the data as far as how many they need. That would be a VA data-driven kind of answer. But I will say that in rural communities, as you know, they do have bandwidth issues. And if a veteran can't get to the technology that's supposed to help them because they don't have the capacity to do so, then how is technology supposed to be helping that veteran? So the clinical resource hubs are really beneficial for the rural veteran to be able to get the quality care that VA provides. And so they do have efforts such as the virtual living room where you can go to, say, your local DAV chapter and have a private conversation with your provider using these clinical resource hubs or these virtual living rooms as well.
I want to hear what you had to say, but I also thought of another issue.
Sure.
So, employment, and what do we know about that? If they still pause, what's it called? Oh, yes. I couldn't hear either. So, related to these topics, the Atlas Pods was something that was touted. We have one in Kansas, in Emporia, in which mental health services were to be provided so that a veteran who didn't have access to the technology or the broadband width to receive and send signal to a provider could go to a central location within the community. In this case, a veteran service organization worked with a private company to put in the pod. The VA has paused the implementation of that. Do disabled American veterans know about that program? Anything that you want to share with me, or just I'll use this as an opportunity to remind myself and the VA that pause has been going now for months?
I do not know about that program, but I'm very interested to hear about it.
Okay, you think it could have merit?
I don't know. I would have to look at it.
Okay. Anyone else? Thank you very much all for your testimony. I want to thank you. I do thank you for being here. We'll continue to make certain that we do everything we can to see that veterans receive high-quality care, particularly as it relates in this hearing to mental health and substance abuse disorders. And I'm grateful for the care and compassion that each of you have shown for those who served our country. One reason I was late, incidentally, is today is the 248th anniversary of the Army, and so we were cutting cake. And I chair the Army caucus, and I was responsible for helping cut the cake. But I'm glad I made it to hear the testimony that I did and to have the conversations with you. We'll keep the record open for a week in case my colleagues and I have questions that you can then reply to the record. And for today, the hearing is adjourned. Thank you.